Welcome back. Our third causative agent is cytomegalovirus. Cytomegalovirus is considered the most common congenital viral infection. Transplacental transmission can occur at any stage of pregnancy. Viral infection during pregnancy might be primary, reactivation, or recurrent. Only 10% of cases develop manifestations of intrauterine infections. Actually, 90% of exposed cases are asymptomatic but may develop later deafness or learning problems. Congenital cytomegalovirus infection has several manifestations. These manifestations include intrauterine growth retardation, progressive sensorineural hearing loss, chorioretinitis or optic atrophy, microcephaly or hydrocephalus, intracranial calcifications, mental and developmental retardation, hepatosplenomegaly, jaundice, and thrombocytopenia. This CT brain shows dilated ventricles and intracranial calcifications, and this photo shows microcephalic baby. Diagnosis of cytomegalovirus infection is by PCR from the infant or cord blood, urine culture for cytomegalovirus in the first 2 weeks of life, imaging studies as transcranial ultrasound, CT brain, or MRI. Treatment includes ganciclovir therapy, which should be used if there is severe end organ disease as pneumonia or hepatitis or viremia. Some studies recommend its use in any symptomatic case to improve neurodevelopmental outcome. Its role in long-term prognosis of asymptomatic cases is still not proved. Regular audiology and ophthalmology follow-up is needed. Serial, occipitofrontal, and developmental assessment is also indicated. Next, we have congenital herpes simplex virus infection. Herpes simplex virus infection is usually acquired at birth during transit through an infected birth canal, which means this transit is in an infected birth canal during labor. The mother may have either primary or reactivated secondary infection. Primary maternal infection, because of the high titer of organisms and the absence of antibodies, poses the greatest risk to the infant. The risk of neonatal infection with vaginal delivery in this setting is 25 to 60%. 70% of mothers with primary herpes at the time of delivery are asymptomatic. The risk to an infant born to a mother with recurrent herpes simplex is much lower. It's less than 2%. Clinical manifestations include 3 entities: localized skin, eye, or mouth disease, multi-organ disease, and CNS disease. Time of presentation of localized skin, eye, or mouth disease or disseminated disease as pneumonia, shock, or hepatitis in the infant is usually 5 to 14 days of age. CNS disease usually presents later at 14 to 28 days with lethargy, fever, and seizures. In rare cases, presentation is as early as day 1 of life, suggesting in utero infection. In about 45% of patients, localized skin, eye, and mouth disease is the first indication of infection. Another 30% present with CNS disease, whereas the remaining 25% have disseminated or multi-organ disease indistinguishable from bacterial sepsis. Unfortunately, not all cases of neonatal herpes present in one of the mentioned categories. Sometimes it's deceiving. That's why herpes infection should be considered in neonates with sepsis syndrome and negative bacteriologic culture results and severe liver dysfunction or coagulopathy. Herpes simplex virus also should be considered as a causative agent in neonates with fever, irritability, and abnormal CSF findings, especially in the presence of seizures. Viral culture from the vesicles, usually positive in 24 to 72 hours, makes the definitive diagnosis. PCR can assist in diagnosis but may be falsely negative in the CSF early in the course. If a CSF PCR is performed shortly after the onset of the symptoms is negative, it should be repeated after several days if herpes simplex virus disease is considered a strong possibility. Acyclovir is the drug of choice for neonatal herpes infection. Localized disease is treated for 14 days, and a 21-day course is used for disseminated or CNS disease. Parvovirus B19. Parvovirus B19 is a small DNA virus that causes erythema infectiosum, fifth disease in children, with a peak incidence at ages 6 to 7 years. Transmission to the mother is primarily by respiratory secretions. 70% of adults are seropositive, which means protected. Infection occurs in seronegative pregnant mother with risk of transplacental transmission 33%. This virus doesn't cause congenital anomalies by itself. The virus replicates initially in the erythroid progenitor cells and induces cell cycle arrest, resulting in severe anemia, myocarditis, non-immune hydrops, or fetal death in approximately 3 to 6% of fetus infected during pregnancy. 85% survive maternal infection with no indication of termination. Exposed mothers need specific serologic testing and serial ultrasound Doppler examinations and percutaneous umbilical cord blood sampling of the fetus to assess for anemia. If the fetus survives, the long-term outcome is good with no late effects from the infection. Congenital Varicella-zoster infection. Seropositive mothers having antibodies to herpes zoster virus may develop shingles. The fetus will not be at risk. While seronegative mothers infected early in pregnancy, chickenpox rarely affects the fetus, and congenital varicella syndrome is rare. It's 1 to 2% after maternal varicella infection acquired during the first 20 weeks of pregnancy. Congenital varicella syndrome presents with scarring skin lesions, limb atrophy, chorioretinitis, cataract, neurologic disability, microcephaly, and cortical atrophy. If the mother develops varicella rash 5 days before or 2 days after delivery, severe neonatal varicella develops with high mortality. Varicella-zoster immunoglobulin should be given to neonates born to mothers with chickenpox 1 week before or after birth. If varicella immunoglobulin is not available, IVIG can be used instead. If this had not been done, subsequent illness can be treated with intravenous acyclovir.